Welcome to the UK Dementia and Palliative Care Conference 2026 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started.
Thank you for the honour of speaking to you today. Thank you for Mark for inviting me, for Justine for the fantastic support getting here and the arrangements. Thank you to Paula for that extremely moving and profound statement. And everything I'm going to show you feels a little bit dry and kind of technical after that. But I think just what I can say from a personal point of view is that I'm a clinician. I meet people living with dementia every week. And so the rather technical, bureaucratic, technocratic language that I speak in my NHS England role is grounded in that clinical experience and meeting people and trying to support them as best I can. So I hope that I can get across you haven't lost sight of that, and it informs and motivates me in what I do. Now then, let's talk a bit about dementia as we see it from NHS England, which, as I said, is numbers and figures, and it looks a bit dry, but I promise you we are trying to make a difference. And here are some of the themes that I'm going to address in my talk today. So if there's time, and there may not be, because we're already running a little bit late, and it is, as Mark says, a military operation, I might be able to say something about dementia prevention, but maybe that's something for later. The number of people in England with a dementia diagnosis is the highest on record, and I'll show you that. And that growth is coming predominantly from people aged over 75, women aged over 75 predominantly. We have some issues in the quality of diagnosis in this country. There's too much variation in practice, and I'll show you that. And part of that is our memory services are very busy, 50% busier than they were before or nearly 50% busier than before the pandemic. And as a result of that, waiting times for a diagnosis are too long. And, as you have heard much more eloquently than I can tell you, support after a diagnosis remains far too inconsistent. But we have this thing called a modern service framework, which I'll talk about, which is an opportunity to adapt to the demographic changes in our society, to the rightful expectations that people with dementia and their supporters have, and try and fix some of these issues. So on here we have the number of people with a recorded dementia diagnosis in England. This is data that's taken from primary care, which is a pretty complete data set. And what you can see is that just before the pandemic, we had about 480,000 people in England with dementia. As people here will know, we lost a lot of people with dementia during the pandemic. About 1 in 5 at least, people who died from COVID had dementia. But since then, numbers have been going up again. And this reflects better diagnosis, but also a trend in our society. As I'll show you in the subsequent slides, the dementias are conditions predominantly, but not exclusively, associated with aging, and we live in an aging society. So that trend now, by Christmas, we had 512,000 people living with dementia in England. That number is going to keep increasing. To exactly where it will peak, we don't quite know. It probably will peak at some point mid-century. And this is the breakdown by age and sex. And each bar there is 5-year age group. And as you all know, men are green, women are purple. That is just a biological fact. And what you can see here is that the population of people with dementia, will come as no surprise to you in this room, is predominantly female. But of course, everyone's affected. Everyone can be affected. And this shows you where the growth has come year on year. So although I, as a neurologist, and I specialise in young onset dementia, I take it very seriously, it's not where the growth is. The growth is in older people. So you can see here that this is the year-on-year growth during 2025. And again, the drivers of growth in numbers of people living with dementia is coming from the older segment of the population, predominantly people aged 80 and above, and predominantly women. So yeah, if you just look, we have already in England, in the space of a year, another 2,500 women aged 80 to 84 with dementia compared to a year before. So this shows you how we need to adapt our NHS and our services for this changing demographic. Now, I want to say something about the quality of diagnosis. So one of the issues we have is that when people come for a dementia diagnosis, it's kind of important to get a couple of things right. So firstly, does that person have dementia or not? And if they have dementia, what type do they have? And that's useful because we're increasingly moving towards a world where we'll have treatments that are specific to the dementia subtype that people have. And also prognosis and management, the issues that come up matter. Your likelihood of having a genetic form of dementia is massively influenced by the subtype that you have. So one of the ways that when I look at the data, one of the ways I think about the quality of what's going on in memory services is, can these services diagnose rarer forms of dementia? And one of the ways we can look at that is to look at integrated care boards, so the ICBs, these are the units of NHS, how the NHS is organised at local level. And we can look at that GP data and we can say, right, what percentage of people living with dementia in each ICB have Alzheimer's disease, have a rarer dementia? So here's the data on dementia of Lewy bodies. And what you can see is that there's a twofold variation in the percentage of people across the ICBs of England in terms of the numbers of people with the percentage of people who've got dementia of Lewy bodies. And it's not a surprise that some of the areas in the country where we know there are people who are very expert in dementia of Lewy bodies, like the northeast of England, for example, there's a major academic centre for DLB in Newcastle. Unsurprisingly, they're at the top. And in areas where there may be less expertise, we don't see it quite so much. So this is something we need to get right. We need the expertise to be distributed more evenly around the country. And this is the same data for frontotemporal dementia, which is a very rare but important cause of dementia. And again, there are some very, very good people doing dementia diagnosis in Bristol, not far from here, and in Somerset, and there, 1.5% of people with dementia in Somerset have frontotemporal dementia. But if you're in, say, Lincolnshire, it's about 0.4%. Now, that can't be because there's really a difference between these two populations. It's because the people doing the diagnosis are different. And so, again, this is a sign that expertise is not evenly distributed around the country. This is a graph that we just produced with academic collaborator of mine, Gemma Hazan at UCL, just in the last few days. And what we've done on here is each of these dots is an integrated care board. And on here is the percentage of the population, the percentage of people living with dementia who have vascular dementia recorded as their diagnosis. We don't talk very much about vascular dementia. It kind of doesn't seem to be on the radar very much, but it is a thing. Okay, on average, about 15% of people in England have vascular dementia. And what we've plotted here is what percentage of the population have vascular dementia versus the deprivation. So this is more deprived and this is less deprived. And what you see is there is a bit of a correlation. So the poorer the area, the greater the percentage of people with dementia are living with vascular dementia. And there's quite an important inequalities angle here, which is that there's a lot of talk about Alzheimer's disease. And of course, Alzheimer's disease is important. It is the most common cause of dementia. And it's one where we are making good strides in terms of understanding the pathology of the disease, and some of those are turning into therapeutics. Modest benefits so far, but this is an area of change. However, there's a danger if we focus all our efforts on Alzheimer's disease that we're going to leave people behind. And who we're going to leave behind? People in the poorest areas of the country. So let's just hold this group in mind as well. Now, this is memory service data. So this is from a different data set. This is from the MHSDS, the Mental Health Services data set. This is data that we pull from the Mental Health Trust, who provide the vast majority of memory services. And what you see on here is the number of people referred into memory services every month. And before the pandemic, it was tacking along at about 12,000, 12,500 per month. And now here we are at the end of 2025, and it shot up to about 18,000 per month. So this is a big increase, and I'm not persuaded that there's 50% more resource going into memory services than there was before the pandemic. So they're having to work quite a bit harder to get people through. And this is a big industry if you think about it that way. This equates to over 200,000 people per year in England coming through memory services. That's a lot of people. And as a result of this increased pressure in the system, which is appropriate, we want GPs to refer people with suspected dementia into memory services, waiting times have gone up. And on here, what we've done, this is data from this is looking at the whole country now, and what we've plotted on here over time is the percentage of people who wait up to 6 weeks from referral to diagnosis, the percentage from 6 to 18 weeks, and the percentage waiting over 18 weeks for a diagnosis. And what you can see is we're now in a situation that 53% of people are waiting more than 18 weeks for a diagnosis of dementia. And that's unacceptable. We can't carry on like this. You can see the trend is gradually going in the wrong direction. So we need to get a grip on this and do something about it. Because, I, for example, there's a charity, there may be people from it here today, called Dementia Forward, who are a fantastic charity, do excellent work supporting people with dementia in Yorkshire. And they have opened their dementia cafes to people who are on the waiting list for a diagnosis. They don't have a confirmed diagnosis. They're almost certainly living with dementia. 2/3 of people referred to memory services will end up with a dementia diagnosis. We can break this down, we can start to turn the screw on bits of the poor regional parts of the NHS. So I gave this talk to the Midlands region last week, and I said, look guys, I'm afraid you're the most challenged region. So in the Midlands, of the ICBs that report the data, nearly 87% of patients are waiting more than 18 weeks. So they've got a job of work to do. And then you might rightly ask me the question, how well does the NHS support people living with dementia? And the answer to that is that we do not have data systems that allow me to answer that question very well. So we've got all this stuff around diagnosis that I've just shown you, but there's very little that we're actually extracting from the record. The record doesn't really give us. We haven't developed the systems to allow me to say the experience that Paul has just described that's a very common experience in Devon and a less common experience in Northumbria, for example. We just don't have that data. The best we've got is the percentage of people who have had their care plan reviewed in the last 12 months. And again, that's just numbers. There's nothing qualitative about whether that care plan review was any good, whether it resulted in anyone actually getting care. What we see, but we have got the data here, I've again split it by ICB, and what we see is on average about 2/3 of people living with dementia do get their care plan reviewed each year in primary care, but it varies. And again, there are some parts of the country where barely half, and others where it's getting to 70%. So again, a lot of variation there. And we do have, this is part of something called QOF, which is an incentive scheme for GPs. And so we do have levers that we can potentially pull to try and drive this up. I don't control those levers, I hasten to add. Now, so that's the sort of perhaps slightly bleak's putting it too strongly, but challenged sort of situation that we're in right now. So let's talk about the future. So the modern service framework, this is what me and my team at NHS England are working, and with colleagues at the Department of Health, this is what we're working on right now. We're about to have our first meeting of our stakeholders next week. Sorry, this week. Time's flying. I think it's tomorrow, actually. And so the background, so you'll have heard of the 10-year plan with the 3 shifts, which I'm not going to read out, but they're on the slide if anyone hasn't yet heard them or heard them lots and lots of times. And the 10-year plan is quite high level. So it's sort of saying, in general, what's the direction of travel for the NHS? But it doesn't say much about specific conditions. So what the government has said is for various conditions, we will have a modern service framework, and that's where we'll get into the detail of how we want care to change in particular areas. And so they said, right, we're going to have one for frailty and dementia. And that's great, actually, because without a modern service framework, you don't get the energy and the focus from the centre, from NHS England or the department. So it is very good that dementia has a modern service framework, shared with frailty, and I'll say a bit more about that in a minute. We won't be able to publish it until Baroness Casey has published the first phase of her independent review into social care. So that will come out hopefully in the autumn, and then we will follow a little bit after that. So on here these are the slides the Department of Health and Social Care have created. So there's not my slides, but this is how they've summed up. And this is just something to do with what we want the MSF to do. So reduce variation, narrow inequality. So sort of, picking up on some of the themes that I've already mentioned, setting national standards, build an ambitious and practical framework, and so on. And it will be it would engage a wide group of stakeholders. Now, something that I think is worth airing is, which people have commented on, not anyone here so far today, but in other settings where I've talked about it, is why is dementia with frailty? And the answer to that is that government moves in mysterious ways. Right? Sometimes things just happen, and no one quite knows why they happen, but they happen. And we have to make the best of it. But actually, the more we think about frailty, the more you realise that it's got a very important role to play in dementia and vice versa. I'll show you some demographic data about frailty in a minute and in the next slide, and you'll see the crossover of dementia is very significant. And of course, because this is a dementia audience, I've put a slide about frailty, and what you have on here is the clinical frailty scale, which is this fantastic, it's often called the Rockwood scale after Ken Rockwood, who's a Canadian geriatrician who developed it quite a long time ago. And it's just this fantastically intuitive scale. It's a really straightforward scale to use. I've used it in my own research. And it really does map on to what's like to happen to people. So it's been validated like hundreds of times. So, and I don't know, I can't tell you exactly how many people with dementia in England are living with various types of frailty, but there is quite a significant overlap. And of course, the more advanced your dementia is, the more frail you are likely to be. And so for this audience, where there's a lot of palliative care expertise, I'm sure for you, the connection between dementia and frailty is quite intuitive. So, and if you look here, so about 10% of people aged 65 and over are living with frailty. Well, what's the number for dementia? About 7%. And again, quite a lot of overlap. And because of the interest of time, I won't go through all of these slides, but there is quite a lot of overlap. And one of the things that we see particularly where there's an area of overlap is people's vulnerability to acute crises and then to ending up in places like hospital corridors, which, as we've heard today, is not an acceptable situation. And so I think that by combining forces and combining the kind of, if you like, the clinical and political and voluntary sector heft of these two conditions, I think we're more likely to get something significant over the line in terms of how we solve this propensity to crisis and to a very sort of unpleasant experience of crisis when it happens. So how's the process going to work? We are going to have to define an aspirational long-term outcome goal. So if you look at some of the other MSFs, so look at cardiovascular disease, for example, which is one of the MSFs that's ahead of us in the cycle, they've come up with a commitment to reduce the number of premature deaths from cardiovascular disease by a certain amount, by a certain year. So we will have to come up with something along those lines. We're still working on that. We will have to identify the best evidenced interventions that will support that, set some standards, and then as to how they're going to be used, and we'll obviously need an assurance system afterwards to make sure that people are doing what we want them to do. The government's very keen that we think about challenge areas where something like technological innovation or scientific innovation might allow us to go even further. And that's quite a challenge to sort of think, well, what might we have in 10 years that we don't have now that no one's thought of yet? That's quite a hard thing to do. And then we need to think about how as things emerge, how do we have an ecosystem that can adopt innovation and spread it around. So at the moment, we are doing all of these things, which you'd expect from any reasonably well thought together sort of policy production process, and developing our governance and getting ready for our first set of meetings. And within that, we are going to, as well as a wider stakeholder group, we're going to have smaller groups where we bring in lived experience, bring in the voluntary sector, bring in industry, bring in the academic sector. We want to hear from everybody. As I said, we are developing our outcome goal. If anyone wants to pitch me an outcome goal, it's got to work for dementia and frailty, ideally, just shout out. And as I said, we can't publish until Louise Casey publishes her report. So I'm going to, in interest of time, I'll skip over, no, I won't skip over that, actually, that's too interesting. So let's think about an area of challenge and how we might address it in the MSF. So this is sort of some of the thinking that I'm doing to kind of get ready for this. So we've got a problem with waiting times. I've shown you that data. How are we going to fix it? So something around making sure the right people get referred, and that people who don't have dementia, and it's quite clear they don't have dementia, don't get referred. So that's so important about how we use our secondary care resources wisely. So quite a lot of people in midlife worry they're developing dementia, but they're not, and they have what I call functional cognitive symptoms. And actually you can tell that in primary care quite readily, actually. So we could help with that. We need to, as part of that, I think memory services need very consistent approaches to triage. They need to have they need to be able to talk to GPs and have a conversation, something we call advice and guidance, or advice and refer. So we need that. And then we need to remove bottlenecks in the assessment process. So a lot of services say to me, well, we can see the patients quite quickly, but we can't get a brain scan on them. It's like it takes 3 months to get a brain scan or get it reported. So we need to remove some of those bottlenecks. And then we need to think about capacity and productivity in memory services, because there's always ways in which you can work a little bit more efficiently and cut out some unnecessary steps if you think about it. I did this piece of work nearly 10 years ago now when I was working with the London Memory Service Network, London Dementia Clinical Network, and we went around and visited most of the memory services in London and several outside London, and did a little bit of pathway mapping to find ways in which we could get services to work a bit more in a slightly leaner way. And that is still live on the NHS England website. So if you run a memory service, and I don't think that's really the focus of most people here, but this sort of stuff has been done. There's prior art on this. And then the government came along very helpfully quite recently and set up this thing called the Dementia Patient Flow Challenge. And this is some new money that's coming from DSIT, so it's not from Department of Health, it's from another bit of government. But this is several £million which you can bid for if you are in the business of creating diagnostics. That could be, so for example, faster MRI acquisition protocols. It could be digital tools that help diagnosis. It could be blood biomarkers. If you've got something that can help, then you can bid for this money. And their aim is to get to the point where by 2029, which coincides with the date of the next general election, most likely, more than 92%. It's interesting how government sort of works to those cycles, but of course, that's the system, isn't it? So more than 92% of people could be diagnosed within 18 weeks of a referral. That's the kind of figure that I'd like to see. And this is some money that actually allows us to bring in some tech innovations to help with that. So that is very good news. I'll just move on to one other thing. So post-diagnostic support. Okay, this is the thing that actually keeps me awake at night, is the inconsistency in care. The fact that the NHS does not have a robust approach to this, that we discharge people from memory services to really a kind of mixture of different arrangements in different areas, where it's unclear, like what's the overall response of the GP versus the voluntary sector versus some of the community team. It really lacks consistency. So what I would like to see is that we set through the modern service framework a minimum standard for post-diagnostic support, at least a floor, right? The base that we can say that everyone should get this, and then a model for commissioning it. We do have an evidence gap for the cost effectiveness of post-diagnostic support models. That's a bit of an issue. So you could spend hundreds of millions of pounds. We've done some costings on this. You could spend hundreds of millions of pounds, but to persuade government to park that kind of cash, we do need to show what we get in return and what are the overall benefits for the system. And that we need the research community to have done some of that work. And there's not quite enough data on that, but we have to do our best. We can learn from things that have been tried at a small scale, like these so-called step-up, step-down models of care. I do think we should be thinking about how we embed dementia care into neighbourhood, the sort of emerging neighbourhood health model and the multidisciplinary teams that we hope will emerge from that. And I would like to see memory services sort of take a bit more of an interest in what happens to people further down the line and use, maybe in a remote way, support the people who are doing the day-to-day case management of dementia in our primary community teams. And as part of this, we absolutely have to maximise collaboration between these different parts of the system, the NHS, social care, and the voluntary sector. And hopefully we will be able to articulate something along these lines in the next 6 months or so. I think in the interest of time, I won't talk about prevention other than to say that it is really hard. Dementia prevention is really hard. And one of the things that I often show this slide, so I'll just preface it by showing this one. What this shows you is the number of people living with dementia in the UK, the prevalence of dementia in the UK, estimated prevalence, from the CFAS study. So CFAS 1 was done in about 1990 and CFAS 2 in 2010. And what you see here on the prevalence data on the left is that the percentage of the population living with dementia, pretty much every age group, has gone down between 1990 and 2010. So although demographic aging means that more and more people are getting diagnosed, individually our risk as we get older is actually coming down. So we're all a little bit more resistant to dementia than our forebears were 20, 30, 40 years ago. And we could speculate as to why that is: better control of vascular risk factors in the population, high levels of education in the population, whatever. We don't actually know exactly. On the right-hand side is the incidence data. That's the number of new cases per year. Also showed a decline across the age course. But if you dig down, what you see, if you then subdivide the population into thirds, and you have the richest third, the medium third, and the poorest third, what we see is that between those studies, all the reduction in dementia risk accrued only to the richest third of the population. So no one else got that benefit. So once again, there's an inequalities angle here. And so if people want to come and talk to me about dementia prevention, and I encourage you to do so, I don't want to hear about things that will only benefit affluent people, because they're already benefiting. I want to hear about something that doesn't help everybody. And that, to me, needs to be a public health-led approach in which we deal with some of the social determinants of health alongside things like, brain health and all of that stuff. Okay, and we did some work. If anyone wants to see what the latest sort of thoughts on this are, I took part in a Delphi consensus process in Nottingham, which was published a couple of months ago, and we came up with some areas where we agreed and areas we didn't agree on. If anyone's interested in dementia prevention and where we've got to, have a look at that paper. So, in summary, what would success look like from the MSF and more broadly? So, speeding up the process of diagnosis, making sure that we get the diagnosis right and we have expertise joined up around the country to achieve that. And I very much I'm a great sort of integrator. I want people like me, neurologists and memory service clinicians and others to work together. I want them to be regionally networked. They can talk to each other about patients and about complicated diagnoses and management challenges. And I think if we do that and we start to break down some of the institutional and professional barriers, we will be in a better place for new drugs if and when they come. I'm often asked, what is NHS doing to prepare for the new Alzheimer drugs? And the answer to that is, the best thing we can do is start talking to each other and breaking down barriers, because to deliver some of these very complex treatments, we're going to need all hands on deck. They're hugely infrastructurally complex. I want there to be national standards for post-diagnostic support. I hope we will have those from the Modern Service Framework. And ideally, what we want is those will result in fewer avoidable crises and admissions. And Tom Downs, who's my opposite number for older people, so he sort of carries the Frailty brief at NHS England, and I do the dementia side. So he is very, very upset and distressed about corridor care, but he believes that it's fixable, and he will point to parts of the country like Walsall, for example, which is not an affluent area, where they don't have corridor care in their hospitals. So there are things that we can do right now to try and fix it, and he should invite him next year to give that talk. And hopefully, I think if we're going to think about the next generation and how we're going to avoid dementia in future for other people, and we won't be able to mitigate all dementia. In England, probably about a third maximum is delayable or preventable. Most people who are going to get dementia are still going to get it, but quite a lot could still be delayed or prevented. But I think we're not going to do that in a piecemeal way. We need a really good joined-up public health-led approach, which thinks about the broader determinants of health. Thank you.
That's it for this episode of the UK Dementia and Palliative Care Conference 2026 podcast. A huge thank you to our headline sponsor Audley, event sponsor Wallens, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.